Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, good morning, good evening, everyone. Welcome to the second point of care testing series webinars. I'm very pleased to moderate today's event for you, and I would like to thank the Saudi Point of Care Testing Association and the Saudi Society for Clinical Chemistry for organizing this webinar, and Nova Biomedical for sponsoring the event. Let me introduce myself. I'm Malak Al-Mish'ali, a consultant clinical chemistry and point of care testing lead in Prince Sultan Military Medical City in Riyadh. Before we starting, just a little housekeeping before we get starting. If you have any questions during the presentation, please type them into the question box in your control panel, and we'll have time for answering all of these questions at the end. This activity will be added 2 hours to the CME hours from the Saudi Commission for Health Specialties. You will receive a survey through email. Please fill it and send it back to us. The hours will be added to you within 2 weeks. Today we are presenting interference and ketone testing presented by 2 speakers, Dr. Jingzi Sherman and Dr. Marcin Patrick from Nova Biomedical. We'll start with Dr. Jingzi. She will talk about COVID-19 patients' bedside glucose management, the impact of ascorbic acid. Dr. Jingzi joined Nova Biomedical in May 2020 as the Director of Medical and Scientific Affairs. She holds an MD degree and a master's degree in pharmacology, and she is certified in clinical research. She brought with her nearly 15 years of experience in the in vitro diagnostic industries with both pre- and post-market clinical research knowledge and medical education public speaking skills. In her previous role at Roche Diagnostic and PerkinElmer, she led global projects that covered various technologies and diseases area. She is well-versed with US, EU, and China regulations. During her spare time, Jingzi enjoyed outdoor activities, photography, and teaches a group of exercise. She lives with her daughter and husband on a farm in Indiana. Welcome, Dr. Jingzi, and the floor is yours.
Thank you so much, Malak. Let me bring the presentation up. Let's start from the start. Can everyone see my screen? Malak?
Yeah. Yes.
Okay, perfect. Well, thank you so much for the introduction. My presentation today will focus on the diabetes association with COVID-19, and then talk about how the accuracy of glucose meters may be affected by some interferences such as ascorbic acid and anemia. At this point, I'm going to turn my video off just so that I have enough bandwidth to navigate through all of the slides. Okay. So this is a disclosure slides, basically to disclose that I am an employee of Nova Biomedical. I work in the Department of Medical and Scientific Affairs, so this is a non-commercial division. Today's presentation is intended for educational use only, to provide scientific and evidence-based data, and this is not for promotional use. We will cover 3 topics, starting from a quick COVID-19 overview, and then look at diabetes association with COVID-19 mortality and how glycemic control management is important to manage these diabetic COVID-19 patients. Then we will cover 2 specific interferences, the vitamin C treatment, that's ascorbic acid treatment, as well as anemia, and how they could affect glucose meter readouts and in turn maybe impact the glucose monitoring and management of these COVID-19 diabetes patients. So let's start with COVID-19 and diabetes. More than a year after COVID-19 pandemic started, some of these basic facts may be quite familiar to all of us. The COVID-19 was first recognized in China, and the first case was initially reported in December 2019. But now it seems that patient 0 may be occurring as early as September or October in that year. One interesting aspect is that COVID-19 clinical features are not that different from SARS. So the mortality rate of COVID-19 is around 2.3%, lower than that of SARS at around 10%, and much lower than the MERS virus, which is around 34%. So one assumption is that because COVID-19 has such a mild clinical picture, it can spread in the community more easily than the other two strains. Now the virus has spread worldwide. Multiple variants were also reported in UK, South Africa, and Brazil. So there were reports about either, these specific variant vaccines that may be under development, or the existing vaccines that may already be able to recognize these variants. So that still remains to be seen. Now, the global COVID-19 infection and death toll, they're tracked on a daily basis since the beginning of last year. So this is a recent screenshot. I took this shot on March the 10th. As you can see, COVID-19 already affected approximately 120 million people with 2.6 million deaths. So that's roughly around 2.2% death rate from those who are infected. As you can see from the left side, these two graphs, the pandemic is far from done and we have a ways to go. So I pulled out some information from the recent WHO live COVID-19 management guidance to look at, this different disease manifestations. As you can see, about 30% of these patients are asymptomatic. So they may help spread the disease, but have no symptoms or signs, and this could pose a challenging situation to contain the virus. Now, for those who have symptomatic manifestations, their incubation time is roughly around 5 to 7 days, and 80% of those are either mild to moderate clinical manifestations. About 15% will require oxygen support getting to a severe situation, and 5% will develop critical conditions such as sepsis, multi-organ failure, acute respiratory stress syndromes. So those who develop severe or critical conditions are usually occurring in these patients who are either at older age or they have underlying diseases such as diabetes and cardiac diseases. So here we use a publication to represent a study of clinical manifestations in COVID-19 and compare that with SARS and MERS. As you can see, the symptoms are quite similar with fever, cough, shortness of breath, nausea, vomiting, diarrhea. The disease also affects various organs and body systems. So for example, the neurologic manifestations are quite common. You often hear patients complain that they lost smell, they lost taste after they were infected with COVID-19. This is a graphic overview of the COVID-19 clinical management based on the disease severity. As you can see, either from asymptomatic, pre-symptomatic to the critical illness, for all of these patients, isolation and either a screening or diagnostic testing for COVID-19 is quite consistent. Now, for those who just had a very mild illness, they don't need additional evaluations. But for those people with moderate illness, they need to be closely monitored or even hospitalized if their disease starts to deteriorate over the time. Now, let's quickly look at the treatment. So the antiviral antibody treatment, they may be most effective when used early, when the virus replication was, at greatest. At the later hyperinflammatory stage, anti-inflammatory, anticoagulants, immunomodulators may be more beneficial at that time. Now let's just went through the COVID. Let's take a turn to look at the diabetes association with COVID-19. Now, this study was a very interesting study. It was published in Lancet Diabetes and Endocrinology. What's good about it is that it's a whole population study. It's taking in about 98% of the entire population in England, and was the first study to investigate the relative and absolute risk of death in hospitals with COVID-19 by types of diabetes, separate between type 1 versus type 2. They also adjusted the key confounding factors. So they showed 4.7% of that population who had COVID-19 had type 2 diabetes, and 0.4% had type 1 diabetes. They also noted the increased risks in those people with diabetes. So about 1/3 of all in-hospital deaths with COVID-19 occurred in people with diabetes. Now, if you look at this graph, it shows the higher odds ratio for death in people with either type 1 or type 2 diseases, compared with those who have no diabetes. Now, the same research group in this analysis, they also did a follow-up analysis of the same data they published in the same journal in October last year. So not only did they show the same messages that we just talked about, they also show that at the peak of the outbreak, so that's around April 2020, about 3,500 additional deaths per week occurred in people with diabetes. So the majority of those had COVID-19 recorded on their death certificate. So that's huge here. And then they also looked at, various factors and how they associate with the COVID-19 mortality. So I excerpted a portion of the table showing here on the left side. So from here, you can see that HbA1c, renal function as expressed as in eGFR, and the BMI, such as, obesity, they all have independent association with COVID-19 related mortality. So if we focus on HbA1c, those patients, with type 2 diabetes, those patients who have a high HbA1c level at 59 millimole per mole, which is around 7.6% or higher, they have a higher risk compared with those patients who have a lower HbA1c level. So what does that mean? That points out that the long-term glycemic control is important and can tie to a better outcome of these diabetes patients who are infected with COVID-19, the SARS-CoV-2. So the authors also pointed out, compare with renal function here or the obesity here, HbA1c is actually much easier to be modified with the healthcare intervention. So really advocate continual adherence of the guidance and the strengthening clinical services for these diabetes patients in the COVID-19 pandemic. This is a similar study here, looking at a similar endpoints. The study was actually done in China, in the same province here where COVID-19 was first identified. So you look at also a large population, 7,300 patients, about 13% had type 2 diabetes. They showed those people who have type 2 diabetes has significantly increased medical interventions and also mortality risks. But for those patients, with T2D, the type 2 diabetes, if they're well controlled blood glucose regulation, so at or below 10 millimole or 180 milligram per deciliter, they fared much better than those patients who do not control their blood glucose that well. So this finding also provides clinical evidence correlating with blood glucose monitoring and control with improved outcome in this group of patients in the COVID-19. So when we look at all these data coming from UK as well as in China, we see several take-home messages. One, those people with diabetes have a higher risk to die from COVID-19 or develop more severe complications So they really should take extra precaution, either not avoid being affected and take precaution and extra care to keep their blood sugar under good control. Now, if they are infected, the healthcare professionals as well as the patient should maintain their blood glucose in the right range in addition to other needed treatment. So with all of this, we can confidently say that accurately monitoring glucose levels in the diabetic COVID-19 patient is very critical. So that leads to our next two topics. Let's first take a look at how interferences such as vitamin C, ascorbic acid treatment in COVID-19 and how this may affect the glucose meter. So vitamin C is a water-soluble vitamin, so it could benefit those patients who are in the severe and the critical illnesses. The actual mechanism is not well known, but vitamin C is an antioxidant. It has anti-inflammatory properties, immune-enhancing properties, and potentially antiviral properties. As you can see, the New York hospitals was already using vitamin C at the beginning of the pandemic to treat these COVID patients. And then in the middle of the picture here, you can see some publications here talking about using vitamin C either in Canada or in the US. On the right lower here portion here, I excerpted a report that shows a success story of using a high-dose vitamin C that reversed a deteriorating condition in the old female who were infected with COVID-19. What's interesting is across this, they all used high-dose IV vitamin C that's ranging from 6 grams to as high as 24 grams per day for multiple days. So are there any data to support such type of treatment? Actually, there were publications that shows vitamin C may reduce or shorten the length of ICU stays and the duration of mechanical ventilation. So this was a recently published meta-analysis that's done in 2020. They looked at 9 different trials and found strong evidence that vitamin C can shorten the duration of mechanical ventilation. Although this publication also shows some heterogeneity between one trial to another, as far as the baseline of ventilation in the control group, the other thing that I think is of interest is that they showed the use of ascorbic acid is quite different from one trial to another. Some of the trials use the oral administration, vitamin C as a few grams a day, orally administered. And some other trials showed venous infusion of vitamin C that can go from a few grams a day to up to 90 grams per day. So the author here that, they concluded, they said different doses should be really compared directly in future trials to see whether really high dose is going to be beneficial or not. Now, here's another study that was published on Chest, and the authors looked at a combination of hydrocortisone, vitamin C, and thiamine, the combination of that to treat severe sepsis and septic shock. So it's a before and after design. They looked at 47 patients during the 7 months period that were on this combination of treatment. And then the previous 7 months, also 47 patients who were not on the treatment. So quite visually on the right side, you can see the patients who underwent this combination treatment that including vitamin C has a significantly lower mortality at around 8.5%, compare those in the control group around 40%. So they show that this combination that including vitamin C is an effective way to prevent progressive organ dysfunction and the reduced mortality of patients with septic shock or sepsis. So of course, the natural question is, well, does vitamin C treatment will benefit the COVID-19 patients? The studies actually gained traction from 2019 to 2020, during this pandemic, particularly in the last year. So if you do a quick checking the clinicaltrials.gov in the US, you can see 56 studies were listed that were done either in Europe, China, US, and the one study here listed that's actually done being conducted at Saudi Arabia. But even with this, 1 year after the pandemic, the evidence is still not quite consistent. You can see some of the publications, such as on the left top here, they're still talking about in vitro evidence of how vitamin C may be beneficial in the acute respiratory distress syndrome. But if we focus on the right, in the middle or the right lower, these two publications are very interesting. The one publication in the middle that shows vitamin C will improve the oxygenation in the critically ill COVID-19 patients, and they used a venous infusion of vitamin C as high as 24 grams per day. But, well, there's maybe some positive effect there. But if you look at the right lower portion, they're using oral administered vitamin C, also around 24 grams, but different route of administration. Here, the patient population is different. They're looking at mild to moderate outpatient population, but here they didn't show any major improvement in the symptom length reduction. So with this, if you go to NIH website, they basically say, well, currently we don't have enough data for the panel to recommend either for or against the use of vitamin C in the COVID-19 treatment. But it's important to note that high circulating concentration of vitamin C may affect the accuracy of point of care glucometers. So why does NIH mention that? Because there are already known factors, either as environmental factors, endogenous factors, or exogenous factors, that have already been reported that can affect point of care glucose meter. And this includes ascorbic acid as an exogenous interferences. So if we look at some evidence here, here is an experiment that was done in vitro. So they add various amount of ascorbic acid into the sample and then test these samples on different meters. So you're seeing here at a low glucose level, only 1 meter, so that's the stat strip meter, actually looked really well, even as the ascorbic acid concentration increases. It matches with the reference method quite well. The other meters do not do so well. So the study pointed out it's particularly critical when the glucose level is low, that the glucose meter needs to correspond with the reference method well in order to allow better glycemic control. Now, I do want to point out something because we talked about different routes of administration of ascorbic acid. In the oral administration for the ascorbic acid, the blood concentration rarely go above 3 milligram per deciliter. So you can see on this graph where these meters will fare out, it's okay. But when you have intravenous infusion of ascorbic acid, vitamin C, let's say at a 10 gram per day, the blood concentration can go as high as 20 milligram per deciliter. So imagine how that may affect some of the glucose meters here. So here is another example, an 81-year-old female. So this is a case report. Just underwent coronary artery bypass graft surgery and took 10 grams of ascorbic acid every 2 days to help with the wound healing. So this patient actually was pre-diabetic. So of course she was under very close glucose monitoring using a point of care glucose meter. But the staff quickly recognized after the ascorbic acid treatment started, the patient consistently have a 200 milligram per deciliter glucose level. So they started giving this patient insulin, started with 9 units in 24 hours. Then they showed that the point of care device still showed above 200 milligram per deciliter. So they start adding the insulin to 10 units and then later on to 25 units. Now, at this point, they recognize that the metabolic panel done at the central lab actually shows much lower, about 100 milligram per deciliter lower concentrations in plasma glucose. They recognize that the point of care devices may not be that accurate. That's the time they stopped insulin. So the author really said that the physicians need to understand the limitation of certain blood glucose meters, that they may be affected by these type of interferences. They also said, it's important to understand the pharmacokinetics of ascorbic acid and wait at least 8 to 10 hours after the intravenous ascorbic acid before coming back to use the point of care blood glucose meters. Well, here's another study, also a case study, was a 29-year-old man with 90% total body surface area burns. So the ascorbic acid here was also dosed, infused in this patient. Here the author compared 2 different devices, the GMS-1 and GMS-2. What they showed is that GMS-1 is not affected by the interferences and compare really well with the gold standard plasma glucose values. Now, in contrast, the GMS-2, here is the empty circle, that device generate erroneously high results after the ascorbic acid infusion. And this could lead to excessive insulin dose and increased risk for hypoglycemic events. So they really recommend using caution when use these non-correcting point of care glucose devices in those patients who may receive the ascorbic acid therapy. Now, this is an extreme example where it was reported publicly that using a point of care glucose meter in the patient with ascorbic acid led to a wrong insulin administration and the patient later died. So there was actually labeling in the device that warns that ascorbic acid higher than 3 milligram per deciliter. So anything that's higher than orally administered vitamin C can lead to falsely high blood glucose results. So this really re-emphasized the need for the healthcare professionals to understand the limitation of certain glucose meters, when to use them, when not to use them, and how to select the appropriate devices that may not be affected to support the glycemic control. Now let's come to the last topic here. So we just talked about some exogenous interference such as ascorbic acid, but anemia as an endogenous interference can also affect the glucose meter results. This is another one that frequently seen in the diabetic and the COVID-19 patients. So several publications link anemia independently with COVID-19 severity and even mortalities. Anemia is also under-recognizing the diabetes patients. So therefore, when you think about managing the diabetic COVID-19 patient, it will be really important to consider how anemia could affect the glucose meter readings. So for example, in this study, 46 cardiothoracic surgery patients, their arterial blood was taken for the point of care glucose determination, and then their serum was sent to the central lab for determination. So you can see as the differences between the two methods really widens as the hematocrit decreases, so when the patient is anemic. So from this scatter plot here, there's really no correlation between the point of care device versus the central lab method. So of course, this will lead to concerns of using inaccurate point-of-care devices to provide tight glycemic control in patients with low hematocrit. So that's certainly of concern. Now, if you look at this, this is a prospective observational study with 60 arterial blood gas samples. And the hematocrit range from 19 to 60%, with the glucose level also range from 59 to 296 mg per deciliter. So really cover all these spectrums. The absolute difference between the devices versus the central lab method was plotted against hematocrit. So they also looked at two different type of devices. As you can see here, the device 1, GMS1, the dark black circles here, they were unaffected by hematocrit, showing comparable results versus the central lab results. But if you look at the empty circles, the glucose meter 2, it shows an inversely proportional relationship with hematocrit. So that means at low hematocrit range, it shows falsely high glycemic results, and this could lead to excessive, wrongly insulin administration. So this one is done to observe how different hematocrit affect the glucose meter results. So quite similar to the above studies, as hematocrit increases at either glucose concentrations here, either be low or high, you can see that only 1 meter here, stat strip meter, showed consistent readout, more or less. All the other meters showed an inverse relationship compared with the central lab results. So that summarized that anemia here, especially on the low hematocrit level, could lead to potentially falsely high glucose results, and then in turn can lead to wrong treatment in this group of patients. So as we finish these two interferences, what are our take-home messages? So what we are seeing in these studies and case reports can be summarized in the top arrow here. So the interference can result in inaccurate estimation of glucose. We talked about ascorbic acid and hematocrit, but there can be other things that can happen. So when that happens, inappropriate treatment and untoward patient adverse events could happen. So what is observed here not only pointing to the need to increased awareness of some of these interferences could lead to wrong result, but also call for better glucose meter technology and design so that they can consistently eliminate interferences, provide accurate results, and help with the patient management. So in summary, as we consider the improved diabetes patient outcome with or without COVID-19, and bring quality into the point of care devices in the glucose monitoring, it really starts with the education and the raising awareness about the potential for false blood glucose values with certain drugs and interfering substances. And this should be followed by the need to verify point of care glucose accuracy, either selecting suitable glucose meters or add central lab glucose testing where necessary. So keep in mind here, the goal is really to treat those patients, not treating based on the glucose meter results. So the healthcare professionals should really correlate signs and symptoms with glucose readings before administering insulin, especially when that reading is extremely high or extremely low. And lastly, be prepared that errors can happen. So establish written guidelines for early error recognition and prompt responses, and periodically review the quality metrics. So with that, I'm coming to the end of my presentation. Thank you so much. I'm getting this back to the moderator, Dr. Malik.
Thank you very much, Dr. Jingsi, for this informative presentation and important topic. We'll leave the question till the end of this webinar, and let me introduce our next speaker, Dr. Marcin Patrick. Dr. Marcin Patrick, he joined Nova Biomedical in December 2018 as the EU Senior Director of Medical and Scientific Affairs. Dr. Marcin holds a PhD in biology and MBA and fields based in the science-business interface. His combined knowledge of technology, production processes, and regulatory quality requirements helps him to manage the successful product development process. His career involved from scientific to higher management with growing experience in healthcare, medical devices, and POCT diagnostic. Marcin has expert hands-on knowledge in the in vitro diagnostic industries and laboratory techniques. He also possesses broad understanding of the diagnostic sector and emerging technologies, focusing on microfluids, biosensor, immunotechniques, and biochemistry. Marcin has the experience with both early stage and established companies, accomplished at the both strategic and tactical elements in commercializing technology. He has global multicultural management experience, and his multilingual Polish, English, and Spanish Marcin's scientific background is proven by the top publications and scientific honors. Welcome, Dr. Marcin, and the floor is yours.
Hello, everyone. I hope you can hear me, and I hope you can see me. I'm sorry for a tiny delay. I got some technical problem. My slide got deleted, but I managed to upload it again. So I did exactly as Jingsi did. I will start with the camera, and then for any technical problems, I will just turn off and continue, okay? I hope you can hear me.
Yes, clear.
First of all, I would like to thank the organizers for inviting me to this Congress and giving me the chance to share this webinar with all of you. My name is Marcin Patrick, and I'm Senior Director of Medical and Scientific Affairs in Europe for Nova Biomedical. Today, we will talk about the importance of ketone measurements. What, why, and when we should measure ketones. And here's our agenda for today. We will start talking about ketones in general, and then how to measure them. Then we will talk about why we should and need to measure ketones. And then we'll look on the clinical perspective and review a few of the recent publications, including the COVID-19 situation. And we will finish with a brief summary. So what are ketones? Ketones are substances that our body makes if our cells don't
Dr. Marcin? Okay, let's give Dr. Marcin a few minutes to coming back to the room. Hello, Dr. Marcin, are you back?
Yeah, I'm back.
Okay.
Diabetic patients, diabetic ketoacidosis, DKA, a severe complication of diabetes that can lead to coma or even death. During analysis, we can detect three types of ketones. Beta-hydroxybutyrate, which accounts for the majority, over 80% of all ketones, and then acetoacetate and acetone, which accounts for less than 20% of overall ketone bodies. As I said before, ketone bodies refer to three molecules: acetoacetate, beta-hydroxybutyrate, and acetone. Beta-hydroxybutyrate
It's okay. Maybe Dr. Martin faced some network issues with the connectivity. So stay with us. We'll give Dr. Martin a few minutes to come back live. Yeah, he's back.
I'm sorry, I have some technical problems with the Wi-Fi connection. Can you hear me?
Yes, it's fine. You can continue.
Okay, it just disconnected and disconnect me from the room. Sorry for that.
It's okay.
I'll start from scratch here. As I said before, ketone bodies refer to three molecules: acetoacetate, beta-hydroxybutyrate, and acetone. Beta-hydroxybutyrate is formed from the reduction of acetoacetate in the mitochondria. These two predominant ketone bodies are energy-rich compounds that transform energy from the liver to other body tissues. Acetone is a minor product generated by spontaneous decarboxylation of acetoacetate, and it's responsible for the sweet odor on the breath of individuals with ketoacidosis. As shown on the schematic here, ketone body metabolism includes ketone body synthesis, ketogenesis, and breakdown, ketolysis. When the body goes from the fat to the fasted state, the liver switches from an organ of carbohydrate utilization and fatty acid synthesis to one of fat acid oxidation and ketone body production. This metabolic switch is amplified in uncontrolled diabetes. In these states, the fat-derived energy, the ketone bodies, generated in the liver enter the bloodstream and are used by other organs such as brain, heart, kidney, and skeletal muscle, as shown here on the right. Ketone bodies are particularly important for the brain, which has no other substantial non-glucose-derived energy source. If we start to see increased concentration of ketone bodies in our bloodstream, we can define it as ketonemia. In case of acetone bodies, it's acetonemia. Ketonemia is defined as the appearance of high concentration of ketone bodies in the blood during hunger, diabetes, in fever, following surgery with predominantly fatty foods, or after prolonged vomiting. Ketonemia is also defined as an increased blood concentration of ketone bodies caused by increased ketogenesis or impaired breakdown of the ketone bodies. The increased concentration of ketones in your bloodstream, ketonemia, may lead to ketoacidosis. A especially dangerous case of ketoacidosis is the diabetic ketoacidosis, DKA, which happens when the diabetic patient has a problem with insulin deficiency. There is a specific group of patients that suffer from diabetic ketoacidosis that are under SGLT2 inhibitor therapy, and we will talk about it in a specific webinar dedicated just to these patients. We can also observe an alcoholic ketoacidosis or ketoacidosis due to genetic causes, so-called SCOLD syndrome. As a consequence, you can have ketoacidotic coma with potentially untreated fatal outcome. It is important to measure ketones together with glucose in the management of the diabetic patients. As I said before, ketone measurements is very important in DKA, but it's also important to measure ketones in other indications such as GSD, glycogen storage disease, or ketogenic diet, which is widely used to improve epilepsy patients. But mostly the focus in ketone measurements is used in the diabetic patients to avoid, as I said, the main complication of diabetes, the diabetic ketoacidosis, DKA. So how can we measure ketones? We can measure ketone bodies either in a central lab or using point-of-care meters. In the central lab, the method used most widely is photometric, using beta-hydroxybutyrate dehydrogenase. Other ketones can be measured in a semi-quantitative way using so-called urine sticks, and we will talk about it later on, and we'll tell you why you should not really use the urine sticks. The point-of-care meters using the strip-based technology for the detection of beta-hydroxybutyrate. There is also external quality program for point-of-care meters supplied by Randox to calibrate the central lab methods, blood gas analysis, etc. As I said before, diabetic ketoacidosis is the severe complication of diabetes that occurs when your body starts to produce ketones. Beta-hydroxybutyrate is the major ketone in the body that you can find produced in the liver due to the oxidation of the fatty acids. Now, this condition develops when your body can produce enough insulin and break down glucose as a main source of fuel. As a result, instead of using the glucose, your body begins to break down fat as a fuel. This process produces a buildup of ketones in the bloodstream, eventually leading to diabetic ketoacidosis. Patients with type 1 diabetes or those that frequently miss insulin doses do have the highest possibility of developing the diabetic ketoacidosis. DKA is usually triggered by illness or a problem with insulin therapy. An infection or other type of illness can cause your body to produce higher level of certain hormones, such as adrenaline or cortisol. These hormones counter the effect of insulin, sometimes triggering an episode of diabetic ketoacidosis. So the typical infection is pneumonia and urinary tract infection. Patients that frequently miss insulin doses or have inadequate insulin therapy can have a problem when they have not enough insulin in their system, which can also lead to diabetic ketoacidosis. We can find recommendations regarding ketones testing in various clinical guidelines. All the medical guidelines outlined here, ADA, American Diabetic Association, Diabetes UK, European Society for Pediatric Endocrinology, all agree that glucose typically greater than 250 mg per deciliter, combined with elevated blood ketones, indicate probable DKA. According to the guidelines, indication for ketone testing in the hospital includes all cases of hyperglycemia, glucose above 250 mg per deciliter, in combination with an acute clinical condition such as emergency situation, post-operative period, intensive care, major dehydration, anuria, etc. Also, in all cases of hyperglycemia when a diabetic patient is hospitalized. And also during acute illness or stress or when blood glucose levels are consistently elevated. The International Society for Pediatric and Adolescent Diabetes, ISPAD, advocates the use of capillary blood ketone testing methods that quantifies beta-hydroxybutyrate for diagnosis and monitoring treatment of DKA. As we can imagine, adoption of these guidelines will result in a significant increase in whole blood ketone testing in hospitals and could result in more combined glucose and ketone diagnostic approach for patients' management. Early diagnosis and treatment of patients with DKA is important to avoid significant morbidity and mortality. In a paper published in 2008, Sheikh et al. Stated that testing of beta-OHB allows rapid diagnosis of DKA
or a redirection of diagnosis among acidotic patients presenting to the ED. In 2007, Charles et al. Stated that blood ketones are a useful tool that allows clinicians to immediately distinguish between simple hyperglycemia and potentially life-threatening ketotic states. In 2006, Nenheim and al. Stated the point-of-care test for beta-OHB is more useful than glucose alone for the diagnosis of DKA and offers immediate diagnosis of patients at triage. As shown here, the Joint British Diabetes Society recommends the use of whole blood ketone testing, beta-OHB, for diagnosing and monitoring treatment of DKA. They also advise that patient management is based on reducing blood ketone levels in conjunction with other established parameters. And obviously, reducing blood ketone levels meaning monitoring and measuring of ketones over time. Here again, in the Guidelines for the Management of Diabetic Ketoacidosis, written by the British Society of Pediatric Endocrinology and Diabetes, the authors stated and recommend to use capillary blood ketone measurements during treatment, and also, again, blood ketone measurements if pH is not improving. As I said before, blood ketone testing improves the outcome of a DKA patients, especially in the ICU, PICU wards. As published in 2007 by Noyes and al., DKA patients monitored by the measurements of blood beta-OHB left the ICU more than 6 hours earlier than patients monitored with urine ketones. That's almost 30% cost saving for lab tests and 70% reduction in clinical assessment. Similarly, as published in 2002 by Vanelli et al., DKA patients monitored by blood ketones reached the endpoint for intravenous therapy after 17 hours versus 28 hours for patients monitored by urine ketone testing. Now, how can we measure ketone levels? I just mentioned that some of the ketones are measured in urines by so-called urine sticks. The measurement in urine can be done in the lab or in a POC format, and it's always semi-quantitative. Most importantly, what it measures is acetoacetate. It does not measure beta-hydroxybutyrate. Beta-hydroxybutyrate, as we said before, is over 80% of ketone total, and you can measure beta-OHB in serum or plasma in the point-of-care format or in the central lab, or you can measure it in the whole blood as a point-of-care test. Now let me pause here for a second and tell you about the key points of blood ketone measurements versus urine measurements. Now in urine, you can measure the ketones that are in the bladder, in the urine, for several hours. Therefore, testing for urine ketone is, so to speak, a historic rather than real-time monitoring. As I said previously, urine testing measures primarily acetoacetate, not
Okay, we'll wait to Dr. Marchant to come back to us. Yeah, welcome back, Dr. Marchant.
I'm sorry, it looks like I got disconnected.
That's okay.
Disconnected again. I'll try to continue.
Urine testing also has a lot of interferences that give false positives, including nitroprusside, a common anesthesiology agent. Advanced DKA patients are usually dehydrated and therefore are unable to provide their urine sample. Severe DKA patients might be unconscious and therefore unable to urinate. The ADA recommends that urine ketones not be used to diagnose or monitor treatment of DKA. As I said before, they recommend whole blood testing for beta hydroxybutyrate. Additionally, urine test strips are easy to misinterpret because over time and exposure to air results in incorrect readings. And finally, urine test strips typically have a short life, so user must be careful when to use them and avoid expired strips. There are many papers from many different authors talking about the importance of ketone measurements and specifically beta-OHB. In the papers by Rivers and al. From 2006, the authors stated clearly that beta-OHB testing is faster and more sensitive than urine ketone testing to detect DKA. Also in a paper from 2008 by Sheikh Ali and al., the authors stated that beta-OHB allows rapid diagnostic of DKA or a redirection of diagnosis among acidotic patients presenting to the ED. Additionally, and importantly, Wallace and al. In 2001 stated that the rate of fall of beta-OHB in DKA can be used as an indicator of the adequacy of treatment. Ketone testing is also specifically useful in the outpatient centers and diabetic clinic. It provides a simple patient monitor tool of blood ketones during sick day visits. It also provides a rapid identification of developing ketosis and may prevent hospitalization. Simple verification of patients' ketone along with a glucose after insulin pump failures or a non-compliant patient. It is also a better alternative and more accurate than urine ketone strips. Well, apart from general medical guidelines that we just discussed, I would like to put your attention to the recent publication and case study related to diabetic patients infected with the COVID-19. As you can see here in a very recent paper from August this year, 2020, the authors are pointing out that the viral infections in diabetes type 1 patients, including SARS-CoV-2, can lead to so-called acute diabetes. It has been observed and published recently that diabetes is the most common comorbidity in COVID-19 patients, and that includes type 1 and type 2 diabetes. In the Italian studies just published, over 30% of the diabetic patients died when they were infected with COVID-19. Diabetes patients that are also COVID-19 positive has a significantly increased risk for severe outcomes, and they show the highest risk of DKA development. The authors stated that for those type of patients, the diagnostic and immediate treatment of DKE in the ICU is mandatory. Additionally, and as I mentioned before, patients with insulin deficiency and patients under SGLT2 inhibitor therapy
Dr. Marchand? Okay. Yes?
Yeah, yet again, really sorry for that.
It's okay. You're back now.
adaptive response in different types and stages of heart failure. In the same.
I'm sorry, my slides are not moving forward. Okay, it seems like I have a lot of technical issues. Sorry about that.
It's okay. It's happened.
Yeah.
The authors suggested that the cardiac ketone oxidation is an important player in decreasing the severity of heart failure. Also, that the enhanced level of circulating ketones could potentially improve cardiac function by providing the failing heart with an extra source of energy to improve its contractile function. Importantly, the authors look also on the SGLT2 inhibitors and suggested that along with their role in reducing blood glucose level in patients with type 2 diabetes, this type of drugs have shown decrease in major adverse cardiovascular events and or hospitalization owing to heart failure events in high-risk patients with diabetes and in patients with established cardiovascular disease. So let's take a closer look on the sodium glucose cotransporter 2 inhibitors, so-called SGLT2 inhibitors. As shown here on the graph, this type of drugs inhibit glucose reabsorption from the proximal tubule in the kidney by inhibiting the sodium glucose cotransporter 2, which is responsible for almost 90% of glucose reabsorption in the kidney, thereby lowering blood glucose level. It has been shown that SGLT2 inhibitors lower both fasting and postprandial blood glucose levels, and they improve HbA1c with weight loss and the low risk of hyperglycemia. So what is the possible link between SGLT2 inhibitors, ketones, and possible cardioprotection? As many authors suggest, the SGLT2 inhibitors decrease the risk of worsening heart failure or mortality from cardiovascular events, even in the absence of diabetes. The SGLT2 inhibitor-induced cardioprotection has also been recapitulated in murine heart failure in the presence and absence of diabetes, showing that the SGLT2-induced cardioprotection is not entirely reliant on their glycemic control. It has been shown that SGLT2 inhibitors lower blood glucose level and induce a fasting-like status, and as a result, they increase fatty acid immobilization and increase circulating ketones level. This effect of increase of circulating ketones has been suggested to mediate the SGLT2 inhibitors induced cardioprotection. Additionally, this effect has been shown in the presence and absence of diabetes. All these findings together led to the hypothesis that the ketone might be thirsty fuel for the failing hearts. Thus, enhancing ketone delivery to the failing heart may explain some of the beneficial effects of the SGLT2 inhibitor cardioprotection by supplying the energy-starved heart with an extra source of fuel to support cardiac function. But there is also a dark side of using SGLT2 inhibitors. It has been shown that patients with type 1 and 2 diabetes have increased risk of developing diabetic ketoacidosis when using SGLT2 inhibitors. It has also been suggested that the risk of SGLT2 inhibitor-induced diabetic ketoacidosis can be triggered by a decreased insulin dose, decreased food and fluid intake, intercurrent disease, and a history of alcohol intake. We can see an example of diabetic ketoacidosis here on the left. This is a case of 32-year-old Japanese woman with type 2 diabetes and treated with SGLT2 inhibitors. She was on a strict low carbohydrate diet and on admission presented very low arterial pH and non-fasting serum glucose of 191 milligrams per deciliter. Her laboratory evaluation tests show a severe ketoacidosis. In fact, shortly after, the FDA issued a drug safety communication regarding SGLT2 inhibitors, as shown here on the right. You can see here FDA is warning that the type 2 diabetes medicine that belong to the SGLT2 inhibitor class may lead to ketoacidosis. The SGLT2 inhibitor triggered ketoacidosis in type 1 and 2 diabetic patients may require hospitalization. It is now under investigation of the FDA. Here we have another very recent publication from 2020 from New York Medical College. This is a retrospective observational case study of a very small amount of patients. There are 6 patients included that have diabetic ketoacidosis on admittance and were COVID-19 positive. The data from this study are shown here in the table. If we look on the median values, the HbA1c was close to 13, 12.7, and the pH was very low, 7.05. Also, the ketone value, beta-hydroxybutyrate, was over 4.5 millimoles per liter. Unfortunately, as shown in the table, majority of the patients died. The author concluded that diabetes patients have significant increased risk of diabetic ketoacidosis when suffering from COVID-19 infection. They also show high mortality rate, especially when under mechanical ventilation. The authors also outline the high priority of tight glycemic control in this group of patients. Here we have another recent study from July 2020 with protracted ketonemia and hyperglycemic emergencies with COVID-19 patients. This is a retrospective analytical case study involving 3 hospitals in London and looking at 35 COVID-19 positive patients. The results of this study are summarized in this table. As we can see, majority of the patients were males, almost 80%, and over 80% were type 2 diabetes patients. Importantly, the serum measurements of ketone, the beta-hydroxybutyrate, were extremely high. In the all cases group, 5 millimole per liter, and in the DKA group, 6 millimole per liter median. And when we look on the outcome, both intensive care admission and mortality rate were significantly elevated. The authors concluded that COVID-19 is associated with hyperglycemic emergencies and with overrepresentation of type 2 diabetes in patients presenting with diabetes ketoacidosis and long-lasting ketosis. This is the last publication I would like to share with you today. This is a retrospective analytical case study published in 2020 in Central Hospital, Wuhan. This study looks on 538 COVID-19 patients, and the authors suggested directly that COVID-19 infection may cause ketosis and ketoacidosis. Let's take a look on the data. The data from this study are shown here in those 2 tables. When we look on the first upper table, we have all patients, 658, divided into 2 groups, those that developed ketosis, 42 patients, and the rest. When we look closer on the data, we can see that the patients that develop ketosis has prolonged hospital stay, 19 days versus 16, and increased mortality rate, 21.4 versus 8.9. In the table below, we are looking on ketosis patients only, and they are divided into diabetic patients and non-diabetic patients. When we take a closer look on the data, we can see that the diabetic patients that develop ketosis has prolonged hospital stay of 33 days versus 17 days for non-diabetic patients, and very significantly increased mortality rate, 33.3% versus 4%. Importantly, 27 patients that developed ketosis out of 42 were non-diabetic patients, which is 64.3%. The authors concluded that in those cases, the COVID-19 infection caused ketosis or ketoacidosis and induced diabetic ketoacidosis for those patients with diabetes. In a summary, we have learned today that early diagnosis and treatment of diabetic ketoacidosis is important in managing DKA and reducing morbidity and mortality. We have seen also that it's estimated that 50% of hospital admission for DKA could be prevented with improved outpatient treatment and self-care. We have seen data showing that blood measurement of beta-hydroxybutyrate enables faster DKA detection and improved patient management and monitoring, and it is superior to urine testing. We have looked at several different guidelines recommended the use of blood ketone testing for DKA. We have seen recent papers showing that the diabetes patients have increased risk of DKA when infected with COVID-19. We have learned also that the management of a diabetic COVID-19 patient should therefore include tight glycemic control and diagnosis and immediate treatment in the case of DKA. And that's it for today. I hope you enjoyed today's webinar. Thank you very much for your attention, and please feel free to ask any questions.
Thank you, Dr. Marcin, for your informative presentation. And now it's a time for questions. So please drop your question in the chat panel. We'll give the audience 2 minutes to drop some questions or... Dr. Jengzi, are you with us?
Yes, I'm here. Can you hear me?
Yes, great. We'll wait for Dr. Marcin to come back to us. Yeah, Marcin, you're back. Dr. Marcin?
Yes, I just reconnect again. I'm sorry, I didn't hear anything.
It's fine. We are just waiting for the questions. I think there is a question here. I think it's to you, Dr. Marcin. Is there any guideline regarding ketone assessment for diabetic patients with COVID diseases?
Well, no, as it's not an official guidelines. We just observed the first publication coming in, and as I said, there are general guidelines regarding measurements of ketone and glucose. And as we can see, in many cases, the infection with SARS-CoV-2 can induce ketoacidosis and DKA, and even induce a diabetes. In a sense, obviously, as I was saying. So I think we should follow the guidelines as they are as for today, and just be very aware that close monitoring and tight glycemic control, together with a ketone monitoring to avoid complication, is critical.
Okay, good, thank you. Does that apply for the aspartic acid, Dr. Jengzi, as well for the COVID patients?
Could you repeat your question again? I'm sorry.
Just a similar to the, is there any guidelines regarding the aspartic acid for diabetes patients with the assessment with the POCT meters?
Actually, there's no guideline because as you can see in the presentation, I also show that even NIH or the other internationally recognized organization have not given any guidelines regarding the ascorbic acid treatment. So they all indicated that there is no sufficient data consistently talking about the dose of ascorbic acid or the type of administration, because sometimes it's orally administered and other times it's IV administered. So there's still a lot of questions to remain to be answered for the ascorbic acid treatment. And I think we're all waiting for those 56 studies to give us that answer.
And however, the recommendation is to test the sample, send the sample to the lab, or wait for 8 hours to 9 hours to test it in the POCT, as you mentioned in the presentation?
Well, that's a very good question. So my answer to this is, first of all, making sure that if you do wish to use the point of care devices, making sure that particular point of care device is not affected by ascorbic acid. So as you can see from the presentation, some devices may not be as affected and others will be significantly affected. So this is for the first thing. If you wish to continue to use that, verify the device is suitable to be used when the patient is on the ascorbic acid. Now, if you verified or you did notice that the device does not give you accurate result, then the next step is take that sample into the central lab for testing. Use that result to guide you for the patient treatment. And you're absolutely correct. The recommendation from certain publication, and particularly when you look at the pharmacokinetics of the ascorbic acids, it is recommended to wait for 8 to 10 hours after the cessation of ascorbic acid treatment, particularly for the venous infusion of ascorbic acid, before you revert back to the point of care devices.
Great. Thank you, Dr. Jengzi. Okay, I think there is no more questions. Thank you, Dr. Jengzi and Dr. Marchand, for answering all of those questions and for the great presentation. It was a pleasure to have you with us today. So this concludes the webinar. Thank you all for attending. We hope you have learned and enjoyed our presentations. Just to remind you, the activity will be added 2 hours to the CME hours from the Saudi Commission for Health Specialties. You will receive a survey. Please fill it and send it back to us, and the hours will be added within 2 weeks. Thank you so much. Thank you.
All right. Thank you very much for inviting me, and sorry for the technical problems. Have a good day and stay safe.
Same here. Thank you for the invitation.
Thank you. Bye-bye.
Bye-bye.